Good evening, everyone. A very warm welcome to Pink Conversations, spreading awareness and inspiring actions. Today's session is not just a discussion; it is a collective effort from Voice of Healthcare and Israel Pharmaceuticals to bring clarity, confidence, and courage into the conversations around breast cancer. Breast cancer continues to be one of the most common cancers affecting women globally and increasing in India as well as in South Asia. Yet, alongside the rising numbers, we are also witnessing extraordinary advancements in early detection, precision medicine, survivorship care, as well as patient advocacy. So, this evening, we are privileged to be joined by an exceptional panel of experts from clinicians, specialists, and patient advocates who will not just bring the scientific expertise but also the live experience for working closely with patients and families. So, our session would be divided into two segments. First, where we'll talk about the awareness, risk, and early diagnosis. And on the later half, we'll talk about some treatment advances, survivorship, and support systems. So, to have this important discussion, we have some esteemed panelists with us, starting with Dr. Niti Raizada, Principal Director, Medical Oncologist and Hemato-oncologist from Fortis Group of Hospitals, Bengaluru. Welcome, Dr. Niti.
Thank you.
We Very welcome, ma'am. We have Dr. Ankur Nandan Varshney, Senior Consultant, Medical Oncology from Medanta, the Medicity, Gurugram. Welcome, Dr. Ankur.
Good evening. Thank you.
We have Dr. Ramya, Consultant Medical Oncology from Apollo Cancer Center, Chennai. Welcome, Dr. Ramya.
Good evening. Thanks for having me here.
We have Dr. Hollis D'Souza, Medical Oncologist and Hemato-oncologist from Grace Oncology, Mumbai. Welcome, Dr. Hollis.
Good evening. Thank you.
We have Dr. Lubna Mariam, Associate Professor, Radiation Oncology Department from National Institute of Ear, Nose and Throat, Bangladesh Oncology and Palliative Care Specialist, Dhaka. Welcome, ma'am.
Thank you for having me. Good evening to everyone.
And we have Mrs. Vandana Gupta, founder of We Care Foundation. Welcome, Mrs. Vandana. Ma'am, you are on mute if you were saying something.
Good evening and thank you very much. I hope I can encourage the doctors to look at it from the patient's point of view.
So to begin with our session, we'll first talk about some multidisciplinary cancer care. And I would like to start with Dr. Niti Raizada that, ma'am, as a senior oncologist and leading, multidisciplinary cancer care, how important is tumor biology in breast cancer today? And how do you see the current breast cancer landscape evolving in India, like particularly in terms of early detection and patient awareness?
So thanks so much, Dr. Muskan, for inviting me today. A very relevant topic and a relevant question. Well, traditionally, tumor biology was the most important component. When we had a breast cancer diagnosed, we'll traditionally call it whether ductal type, lobular type. And then we look at the size, tumor size, nodal status, and the stage. And based on that, treatment was planned. And that was normally, it was not a very precise treatment. But then next, we moved to certain things which are known as protein expressions. And we started seeing what is the estrogen receptor, progesterone receptor, HER2 receptor, and what is the proliferation index. Beyond this, we started looking at gene assays. All these things led it to decide whether we can give targeted therapy like anti-HER2 therapy for a HER2 expressing tumor, for a hormone positive hormonal therapy along with CDK4/6 inhibitor, sometimes PIK3 inhibitors. Based on gene assays, we decided whether a patient requires less radical treatment, can just be managed with hormones, or requires chemotherapy. So these were in terms of tumor biology. And again, it is evolving on a day-to-day basis, and everything is becoming more and more precise. This is all about early stage tumors. When we look at advanced stage tumor, again, genomic profiling is extremely important to decide whether we can custom make the treatment for a person's need or a patient's need. Looking at the landscape of breast cancer, which was the second half of your question, well, we know that breast cancer is a leading cause of cancer amongst women in India. But what we also know is that it is becoming now in earlier and earlier age. And there are multiple factors when you look at it. So yes, the diagnosis is increasing. Yes, there was some a tip of the iceberg which we knew, but now we are also getting increasing number because of early diagnosis, which was the hidden patients which are suddenly surfacing. But it's also lifestyle changes, it's urbanization, late childbirth, and so many other factors which are contributing to increasing numbers. Of course, the most important is increasing lifespan, because any cancer is age related. The longer the age, more is the incidence of cancer in that community or in that society. Now, the next thing is, well, our major challenge still remains late diagnosis. Only about 30% of the patients are diagnosed at an early stage, and these are the curable subset. But there are still about 60-70% of the patients who are diagnosed late. And when they are diagnosed, interestingly, in breast cancer, they are still treatable. But this is what spectrum which we can change by talking about it, by bringing awareness and talking about, of course, screening programs. Again, because of the changing landscape, lot of AI utilization, molecular diagnostics, and genomics has come in play. And so the entire landscape of breast cancer has changed radically over the past decades.
Thank you so much, Dr. Niti, for clearing out those landscape evolving in India about breast cancer, and understanding biology. I think is clearly reshaping the tumor outcomes as well. So, building on to that, Dr. Ankur, patients often hear some radical terms like triple negative or HER positive, which may sound overwhelming to them. So, could you explain how subtype classification impacts prognosis as well as urgency of treatment decisions?
So thanks, Muskan. As Niti ma'am has already done the criteria for different biology of the tumors, we know there are various subtypes of breast cancers. As an oncologist, I had many subtypes, and it could be invasive ductal, invasive lobular. Then, depending on pathology, it could be micropapillary, it could be inflammatory, it could be medullary variant. But what is more specific for patient is the expression of genes, which ma'am told, which is the ERPR, HER2/neu, and Ki67, because our main treatment is on the basis of these genes. So the very first subtype is a hormonal subtype of cancer, which includes ERPR positive, HER2/neu negative, and Ki67 could be low or high. So this is a cancer subtype cancer which is having a good prognosis. It is usually found in older women, and many a times, if this is found in low size and low lymph node staging, the patient may omit chemotherapy and can directly proceed to hormone therapy after surgery. So this is the advantage, and this cancer subtype is having the best outcomes amongst all breast cancers. Now coming to another subtype, which is slightly aggressive variant, which is HER2/neu. In this subtype variant, ERPRs are negative, but HER2/neu mutation is positive. Now, HER2/neu is a target gene, and we have many anti-HER2/neu therapy available with us. Outcomes with these is still very good, but these patients require anti-HER2/neu treatment as well as chemotherapy. Now we come to a more aggressive variant, which you quoted, triple negative variant. Now this triple negative variant is when both ERPR and HER2/neu mutations are negative. This is an aggressive variant, usually associated with a high Ki67. And the problem is, this is mainly present in younger sets of women. So And many a times this presents in an aggressive form, could be a large breast tumor, and could upfront present with metastatic stage 4. So this is slightly a difficult to treat population, and these patients do good with the chemotherapy as well as immunotherapy. So these are the major molecular subtypes as per the patient requirement. Otherwise, as an oncologist, we have many subtypes which are there important for it as a disease biology, but contribute less to our treatment.
Thank you so much, Dr. Ankur, for that descriptive response of tumor and subtype classification. Moving onwards and coming to Dr. Ramya, ma'am, there is increased conversation around us that younger women are being diagnosed. So, in your clinical practice, are you seeing a shift in the age profile and in younger women, where breast cancer tends to be more aggressive, or what unique diagnostic treatment challenges arise?
Thank you, Dr. Muskan, for that question. It's quite relevant because, just as you say, quite a few, nearly 25% of the breast cancer seems to be happening in at age of less than 40 years of old. I think that's a significant shift in the last couple of years that we are seeing. And as Dr. Ankur and Dr. Niti mentioned, we do see more of aggressive subgroup varieties in the younger patients, like more of the triple negative and more of the HER2 positive in the younger age group. One difficulty is the younger the disease happens, the more aggressive the behavior, as well as the stage can be more advanced at presentation. And younger age group breast cancers are also associated with more of hereditary breast cancer syndromes. Like we see genes that run in families, which are now easily identifiable, which are now treatable also. So we make it a routine to test all of these young breast cancer patients for those genes to give them the benefit of that treatment too. And as far as the treatment or diagnosis is concerned, now mammogram is something that we commonly know, and it's become very easy for people to access a hospital and ask for a mammogram because the knowledge about screening mammogram is much higher in current times when compared to earlier. But the problem in a younger carcinoma breast is the breast is so dense that an X-ray modality of mammogram might not be the ideal testing. So we always tailor the investigations based on the age. We do a mammogram using an MRI technology so that we can identify and pick it better, because earlier you pick it up, it's always earlier the stage, better to treat, easier to cure. So all those always come in our mind. So, and the most important thing is these women, the young women, do not think that breast cancer can happen in them. They always associate breast cancer as a disease of the elderly. So that also has to be reinforced and explained to them in such a way that 20-25% of the cancers we are seeing in less than 40 years of age. So any doubt, just approach your healthcare provider so that they can assess you and make sure that you don't have any lumps that look cancerous. Do the necessary test that's needed. As far as the treatment is concerned, lot of advances have happened. As I said, we have treatment directed at those genes that are specifically altered. We have immunotherapy as an option for triple negative breast, lot of targeted options for HER2 positive breast. But apart from this, in younger age group, when we talk about treatment, the important concern is about the fertility. Many of them would be still wanting to plan a family, would still be unmarried. So how do we counsel them on fertility management issues? How do we counsel them about the toxicity of chemo, how to handle them, and also the psychological support? All of this becomes important in a younger age group of breast cancer patients, is my opinion.
Thank you so much, Dr. Ramya, for those important insights on the younger women and how they, may not even perceive themselves to be at risk sometimes. So, moving onwards to Dr. Hollis. Risk assessment is a growing area of discussion right now. So, my question to you is that how important, our family history or lifestyle in assessing the risk, and who should ideally undergo genetic testing or genetic screening for BRCA mutations?
Dr. Muskan, so very important and relevant topic in today's age. Young patients want to know whether they have a risk of any cancer, not just breast cancer. So risk assessment, there are multiple models that are available, but they are available online, but they are not for the common public. They can fill in the details, but there are certain details that need to be filled with the oncologist. So in the risk assessment, what are the things that we look for? We look for family history, definitely. There is a lot of personal history that is asked: age of menarche, menopause, the children, any prior biopsy is done. So all these are complicated models. What we look for is what is the outcome of these risk assessment models. The outcome of this risk assessment models is when do you want to start screening, or when which patient do you want to be kept at regular intervals of follow-up or shorter intervals of follow-up. So one of the biggest risks of any cancer, especially breast cancer and ovarian cancer, is genetic. People are worried. There is a family history of cancer in one of the relatives. Will I be having this cancer? So BRCA is one gene that is very common in the is commonly known to the people in the society. So we always ask you, how is it tested? First, people are not aware how it is tested. People feel that it is a part of the mammogram. So BRCA testing is a blood test. We call it germline BRCA testing, and it is not just BRCA gene. There are not many genes associated, called as the hereditary breast and ovarian cancer panel. These are commonly available at a lot of different labs that are recommended by our oncologist. Who needs it? There are criteria determined by multiple societies, especially NCCN guidelines are there. There are criteria for that. So in the gist, if you have a family member with a history of cancer, and not just any cancer, there are specific cancers mentioned that includes breast cancer, ovary, pancreas, prostate. They should assess this risk with their oncologist. Any family member with a risk of or any cancer that is in a younger age group, uh, more than 2 or 3 family members who have cancer, so they should undergo testing. And genetic testing, all said and done, a a structured process. There has to be a pre-test counseling. It's not just to go and order a test in any lab. There has to be a pre-test counseling, followed by a test prescribed by the genetist or genetic counselor, an interpretation by the geneticist and the oncologist, and a post-test counseling. Because BRCA has implications. If it is BRCA1, there are implications of earlier testing. To start a mammogram screening, which we usually recommend at 45, we advise to start that as early as 25 years of age. So very important to understand the process of testing. First is you should know who to be tested. Second is what is the procedure of testing, and third you should understand the implications of that test.
So, Dr. Hollis, as we were discussing about risk assessment and screening, so I have a follow-up question on that. That is there any particular age or particular sign that a general individual should look, and then they should go under screening?
So screening guidelines in India, we usually follow the US-based guidelines. At post 45 years of age, you can go for annual mammogram till 65. Post that either once in 2 years, or you can stop the screening. Symptom-directed treatment is different and screening is different. So there are no symptoms per se that guide your screening. Screening is a test in an asymptomatic individual. Symptom management is different. Anything in particular, if a patient has a strong genetic history, especially BRCA positive, that age shifts to 25. We start as early as 25. In some patients, we start at 35 years of age. We start the mammogram screening once every year at 25, and from 35, we start once in 6 months. And if it is BRCA positive, we have surgeries called risk reduction surgeries. In those individuals, there is a high risk, more than 70% risk of cancer. So in such individuals, we recommend something called prophylactic mastectomies or prophylactic oophorectomies, so that the organ which is at risk for cancer is removed from the body.
Okay. Thank you so much, Dr. Hollis, for that response. So, moving ahead and talking about a regional perspective from Bangladesh, Dr. Lubna, we would like to ask you that in Bangladesh, what are the biggest challenges in breast cancer awareness and early diagnosis, particularly in rural or resource limited settings?
Thank you, Dr. Muskan. Happy International Women's Day. Salute to all the women and their amazing contribution to this world. Dr. Muskan, this question has not a single answer because it's multi-layered problem. And I believe that India, Bangladesh, the subcontinent shared the same problem regarding the awareness of breast cancer. I become oncologist in 2006, and now I told myself as an activist as well, because I have established a foundation to make awareness. So I frequently went to go to the village area to make breast cancer, especially for the women, to make the cancer awareness. And I have found that the biggest challenge, if you ask me, is the widespread knowledge, lack of widespread knowledge and the cultural barrier. When I went to talk about the breast cancer with many women, they don't even know the what is the cancer. They never heard of the word cancer. Many times it's happened. So when I like to teach them about the breast cancer, what is that, it's very hard to make them understand because first of all they don't know the what is cancer, and second, they are very illiterate person. Making them understand about the breast cancer is very challenging. And the cultural barrier, as I told, that people are very, as most of the people are Muslim, they are very shy and they are very shy to talk about the private part. Even when I try to show them the self breast examination, I it was very unsuccessful program. But uh, there are other things as well. Women here, they depends on the it's a man dominated area, so man dominated society. They have to ask the man if they have any problem, and it depends on the cost, also their financial ability. This is from the patient perspective. But if you ask me about the infrastructure, there are also limited resources in Bangladesh where people can go they cannot go very frequently or very easily to access tertiary healthcare, or if you need the specific doctor, specialist doctor, they have to go far away. So they have to visit Dhaka or city places, which is may not be very possible very frequently. So delay is very frequent here. Another issue is the geographical barrier, as I told you, and limited access. The people, the infrastructure, the doctors, the facilities. Like if someone found a lump, even, and they are referred to a tertiary hospital, it is financially they are not able to go very frequently or early to access this FNAC or biopsy, whatever the doctors has prescribed. So limited resources, cost, and the geographical barrier, financial barrier, these all are the limitation for early diagnosis and screening. People are not even aware of the screening. Because early diagnosis saves life, but most of the patients here, like 30 to 40% patients, are very delayed diagnosed and very advanced diagnosed, even more. So we have to make more awareness program in Bangladesh, and government should take initiative to do the screening. This is my thought.
Thank you so much, Dr. Lubna, for sharing those insights. So, ma'am, as you were mentioning about the shyness, so I would like to, ask a bit about more that, despite of increasing awareness, many women they still hesitate to undergo screening. So, could you suggest any practical steps that healthcare systems or communities can take to normalize or regularize breast cancer screening?
Yes, there are some initiative from the non-government organization, that's NGO. They are doing a mobile screening program. So they are very easy, ultrasound in a ambulance or in a van, and they went to village, and they ask the people for they approach the people who have any problem and doing this screening, very ultrasound based, easy accessible and less cost. But people, it should be from an organization. Usually in our country, uh, patient or people are not very uh, intended to go to doctors. So it is very difficult to make them go to the doctor. But if we can take the institute to the patient door, it will be more successful. I believe so.
Thank you so much, Dr. Lubna, for that response. So, moving onwards, coming to Mrs. Vanna, you work closely with patients, families beyond the hospital walls, ma'am. So, from your experience, what are the most common emotional or social challenges that women face immediately after the diagnosis?
Thank you, Muskan. Being diagnosed with cancer itself is a huge problem. because it's emotionally overwhelming, and it's not only the medical treatment, but there is a deep emotional psychological issue that comes up because of the diagnosis. The most common things that I find that we are talking to the patient is, for who are newly diagnosed, is shock and fear, because they are shocked, they are in a state of disbelief, and they can't imagine what life will be with cancer and how it's going to be. So they worry about the uncertainty in life, and they are not very happy. And naturally, nobody is happy on the diagnosis of cancer, but they need a reassurance. And the treatment side effects are not really well known to them, and also the late side effects of the treatment. Even if you get cured, what will happen subsequently? All that needs to be discussed. And the financial toxicity, as the doctor from Bangladesh has mentioned, that's a huge challenge even in India. Then there's anxiety about the treatment, anxiety about the side effects, and the scan anxiety, which means that you have to keep going on for different MRIs, different scans, and you don't know what the results are going to be. So the patients are absolutely worried about it. And for a woman, she's the fulcrum of the family. So being diagnosed with breast cancer is really like taking away the control from her, because she doesn't know what it would mean. There are hospital visits which have to be done. The children have to be looked after by somebody else. She has to depend on the doctors and on the family members, and there's a change in the normal routine. And then, the first fear that comes in is whether it's going to be mastectomy, or whether it's going, I mean, not mastectomy, they don't know the word, whether the whole breast will be removed or only partial breast will be removed. And so that is a fear. And, how will they face society once that is done? Because nobody really tells them at that time that there are processes available, or maybe they are not in a state to understand the thing of processes. So that becomes a big challenge. And then hair loss. Hair, we know hair comes back. We know it now after the treatment is over. But when that is being started, that nobody knows that the hair is going to come back and what will happen to the scars, because it's inside the body. It's not visible outside, but the like the spouse will see it and everybody else will see it and notice it. So how do you cope with that type of thing? So that it's like makes your self-esteem very low, and there's a fear of intimate relationships, and then of course the social isolation, because not many like to talk about the cancer. Not many people come to them to talk, because their thing is, she's got cancer. If it what if it is we have a stigma to it, that if it is infectious, then what happens, and whether others will also get it or not. Then the financial and work stress. Suppose I'm working, then will I be able to continue with my work, or will I have to give up my work? So that is a big thing, because as it is, I'm going to be burdened by the cost of the treatment. And if I have to give up the treatment, my work, then how it's going to be, more. And then, the doctors always say that you will be all right, don't worry. As a patient, the patient hears of a lot of people having recurrence. So there's no reassurance about that whether recurrence can happen. Of course, I know that nobody can reassure you about it, but that also adds on to the anxiety of the person. And there are a lot of mood changes during the treatment. So there is fatigue, there is emotional exhaustion, feelings are not understood very well. So all these things come up. So as I say that cancer not only affects the body, it quietly enters the mind, the family, and every corner of a patient's life. The day of diagnosis is not the day of the treatment. It is the start of an enormous journey, an emotional journey, which is filled with fear, courage, and hope. And patients often say the hardest part is not the treatment, but the uncertainty of what tomorrow will bring. Thank you, Muskan. I hope we can do something more about the patients, and that is why it's important to have support groups where patients can come and openly talk about their feelings, share their concerns, and maybe the spouses can also come there with them, or somebody is the caregiver, because that really helps.
Thank you so much, Mrs. Vanna, for bringing out the patient side, of the journey to us. It was very well explained by you, ma'am. So, moving ahead and talking about some treatment advances and support systems and survivorship in the journey of breast cancer, Dr. Niti, immunotherapy and targeted therapies are transforming oncology. So, in which breast cancer cases are these newer therapies making the biggest difference today, ma'am?
So actually, from a very emotional discussion by Ms. Vandana, I'm moving to again a very technical discussion. Well, yes, a very relevant question again. Immunotherapies and of course targeted therapies have been transformational in the breast cancer journey. Actually, specifically defined molecular subtypes we always see. And as everybody spoke about, we always talk about three important molecular subtypes, where one is the hormone positive, then second is HER2 positive, and third is triple negative. So all these areas have different new applications of newer drugs, targeted drugs, immunotherapy, and of course, targeted drugs are also known as biologic therapy. So when we talk about the first important subset, HER2 positive breast cancer, this is the first subtype which actually showed that biologic therapies actually can be transformational. So when we look at HER2 positive breast cancer, 20 to 30% of all breast cancer are HER2 positive. They can be endocrine positive or negative. And what there are three important successes. First is that we add chemotherapy, but we add a biologic drug, which is an anti-HER2 therapy. Now, this anti-HER2 therapy is a monoclonal antibody, which could be trastuzumab, pertuzumab. There's a newer drug called margetuximab, which also exists. In certain subsets, we use antibody drug conjugate. Antibody drug conjugate means there's an antibody and attached targeted chemotherapy molecule also there. So there is a drug and then there's an antibody. And there are two important drugs, although there are many new which are spoken about. Commonly used are trastuzumab emtansine and trastuzumab deruxtecan. We use them in quite a few settings in HER2 positive breast cancer. Then the third important subtype for HER2 is tyrosine kinase inhibitor. These are oral molecules, and the important past generation was lepatinib. Now we have moved to tucatinib, which is more selective and acts on certain areas like brain. Now the next important subset is hormone positive. This is the most common subtype. Almost 60 to 70% of all breast cancer would be hormone positive. Some of them would be HER2 positive, some will be negative. So hormone positive, the intent is to give anti-hormones or hormone-directed therapy. And how to make hormones more useful is by adding certain things which sensitize the hormone. So we add a class of molecule known as CDK4/6 inhibitors, which sensitizes the response or makes the response to hormones more effective. So we have started adding a targeted molecule called CDK4/6 inhibitors in metastatic setting and now also in non-metastatic setting. Then in metastatic setting, when they have not done so well, we look for certain targets like ESR, which has some SERD inhibitors, PIK3 molecules, by looking at an expression of PIK3CA, whether it's positive or negative. And then the third important category, which Dr. Ramya and Dr. Ankur spoke about, is triple negative. So triple negative is when they are not expressing hormones and they are not expressing HER2. And this is a very unique subset in younger patients, more aggressive, and therefore we need more remedial therapies, which are still lacking. But importantly, chemotherapy has been the backbone, but we always look for expression to make our treatment easy. So we look for whether BRCA is expressed or not, then we give PARP inhibitors. In non-metastatic setting, there's an important role of immunotherapy here. So this is one important area of breast cancer where we commonly use immunotherapy. If it is metastatic, we look for an expression of a molecule called as PDL1 molecule. And if it is expressed, then we sometimes add immunotherapy along with chemotherapy. In if it does not work well, all these treatment in metastatic states have not worked well, then we give again antibody drug conjugate like sacituzumab, and in very rare situation based on low expression of HER2, we give trastuzumab deruxtecan as well. Now, what has been the impact of immunotherapy and targeted therapy? That remains a very important question. What we have been able to achieve is, from moving on from chemotherapy to current generation, we have had improved quality of life. So side effect profile is much more easier, much more manageable. So quality of life has become much more better and survival has significantly improved, especially when we look at HER2. I mean, the survival has significantly improved by adding an HER2 molecule, by adding a hormones plus hormone sensitizer like a CDK4/6. Even in non-metastatic setting, the improvement has been remarkable. And so overall impact have been kind of more comfortable. And that's why we are proud to say that at least breast cancer journey has been in an extent that we can say the past 2 decades have actually revolutionized the entire treatment.
Thank you so much, Dr. Niti, for sharing those medical insights over immunotherapy and targeted therapy and how they have contributed to, improving survival and quality of life. So, coming to Dr. Ankur and talking about treatment adherence, sir, I think treatment adherence is very crucial for any diagnosis of cancer or any disease. So, what factors lead patients to discontinue therapy, and how can doctors and families can ensure the continuity of care?
So, hi Muskan, I will just like to put one correction. Whenever any say that cancer treatment requires adherence, I say adherence is required in any disease of treatment. Either it's a kidney
Correct.
disease or a heart disease or an endocrine disease, all diseases require treatment adherence. So this is not specific for cancer. But yes, cancer is a dreadful disease, and if treatment adherence is not kept, this can lead to devastation. Now, a very significant part of my question have been answered by Vandana ma'am and very beautifully answered. So now let me see as an oncologist how I divide what could be the reasons why patient loss to treatment. So I divide my reasons as medical, then social, psychosocial, and financial. The very first reason is medical. If medical, every therapy has a side effect, every treatment has a side effect. So if these side effects are not well managed, and if there is a persistence of side effect, then many patients left treatment. Now, Niti ma'am has rightly told there were various newer treatments available, and with the development of immunotherapy, with the development target therapy, now side effects are going to a very minor population, and quality of life of most of the patients are well preserved. Even in my day-to-day practice, younger patients are those who are doing their day-to-day routine activities. They are doing their household chores, they are getting their job done, they are attending their family functions while on active treatment. So this scenario is changing. But if certain treatments may cause fatigue, and women's they are many much are horrified with the view of hair loss. So there is a part of medical treatment which may lead to side effects, and these because of these side effects, some patients may lead to treatment disruption. Now coming to the second thing, which is social. Now even in we are living in this century, and even in today, many a patient do not accept cancer diagnosis, and the social support is not very much up to the mark. So many a times due to social reasons, especially because many of patients with hair loss do not go to public functions, and उनको बहुत लोग रोकते हैं टोकते हैं, तो वो लोग कई बार सोशल रीजंस भी होते हैं जिसकी वजह से वो नहीं आते. जैसे वंदना मैम ने बहुत अच्छे से बताया था कि they need support, they cannot take some of the reasons by themselves, and they are dependent on their spouse or other family members to carry a further disease में. तो सोशल सपोर्ट का भी एक बहुत बड़ा रोल होता है. Now coming to the third thing, psychosocial. So there are various myths which are existing behind cancer. And the very first myth is if surgery is done, then treatment is complete. No, this is we are fighting. And मैं अपने पेशेंट्स को बहुत अच्छे से समझाता हूँ कि गांठ निकलना कैंसर ट्रीटमेंट नहीं है. उसके कैंसर का प्रॉपर स्टेज का एक ट्रीटमेंट होता है विच में रिक्वायर टैबलेट, विच में रिक्वायर कीमोथेरेपी, विच में रिक्वायर रेडिएशन. और अगर आप उसको पूरा नहीं कर रहे हो तो आपका कैंसर ट्रीटमेंट पूरा नहीं हो रहा है. तो जो मिथ्स एग्जिस्ट करते हैं, स्पेशली अभी जैसे आप किसी को बताओ कीमोथेरेपी के लिए, वो पहले से डर जाते हैं, इट्स वेरी हॉरिबल. बट वी आर रेनफोर्सिंग. Nowadays many of our patients have their preserved quality of life, and they do their routine activities as they were doing before diagnosis. So these things next has to be clear. And the most important reason जो वंदा मैम ने बहुत अच्छे से mention किया, financial reason. Yes, because now cancer is getting curable, but this is curable because of treatment. और treatment एक बहुत लंबे समय तक continue करना होता है. So not only cancer treatment, but आपको बार बार hospital जाना होता है, and you require certain blood tests, you require certain diagnostic tests, which all these add to the cost. And when financial issues arise, then many a patient leave the treatment. So there are many reasons, and one of the main reason, like ma'am from Bangladesh said, that many on the outskirts of the city, the town and outskirts of the countries, proper treatments are not available. So this is also a reason that patient has to travel from long distance, and when the nearby cities are not having proper treatment, then sometimes patient differ.
Thank you so much, Dr. Ankur, for that wonderful response and clearing I think, the sustained support that is required after the treatment as well. So moving onwards to Dr. Ramya, fertility is often taken as an unspoken concern, ma'am. So, I would like to ask you that fertility preservation is a major concern for younger breast cancer patients. So, what options are available today, and when should these conversations ideally take place?
So I think that's a very important question because fertility preservation is, especially when you see younger breast cancer patients in the clinic, the first question that we'll have is, will I be able to have children after the therapy is over? Because there is always a stigma associated that there's a fertility problem when you receive chemotherapy, and especially the drugs that we use for treating breast cancer does have the risk. So the conversation should begin on day one, especially before we start giving chemotherapy to that particular patient. They should be aware of what to expect, what are the risk of fertility or infertility involved in that particular therapy. Now, how do we bypass that issue? Earlier, the access to do an embryo preservation or an egg freezing, or even the knowledge about egg freezing or embryo preservation, was not that common. It was very, very reserved to a very unique or cliche set of people. But now the concept is also very well spoken about. People are aware of it, and the best way to preserve fertility in especially young women who are going to be undergoing a toxic chemotherapy would be to do an embryo preservation if they have a partner. When that is not feasible, an egg freezing should be done. And even when that is not feasible for any reasons whatsoever, maybe, then we have some drugs that we use at monthly intervals as injections to suppress the ovary and to protect the ovary when the patient is being exposed to chemotherapy, so that we don't kill the eggs that are there. We want to preserve the eggs so that once the therapy is over, then they can talk about fertility, even though our first choice would be either an embryo preservation or an egg preservation. Now, when we talk about the embryo preservation or egg preservation, I should say our fertility counterparts have improved so much. Earlier, we all will be concerned about the timeline that it takes for them to harvest an egg, because it has to be synced with your menstrual cycles. But now they've bypassed all the trouble. They need a week or a 10 days time, and they're able to harvest eggs and freeze it. And earlier, we also will be concerned about the hormonal manipulation that happens during the induction process, but I'll again bypass, because as all mentioned, the endocrine driven breast cancers, that is the breast cancers that are positive for the hormone receptors, grow on these female hormones. So we don't want any manipulation to be happening around there. And the fertility experts have bypassed that also, using drugs that are very safe in the even the hormone positive population, for them to harvest eggs and embryos. So I think this conversation is very important in young patients. Have it in day one, because you cannot separate breast cancer and motherhood. Having a cancer doesn't mean that you cannot be a mom. I think that should be emphasized more, and we should guide them on how to achieve that goal by guiding them to proper freezing options, and taking them through the process. I think that's more important.
Thank you so much, Dr. Ramya, for that response. Also, I would like to ask, ma'am, if any younger or maybe older women get diagnosed, they could have, many questions or doubts or some common myths that they ask you. So, how do you address them effectively?
See, we do have a long conversation with them. As said, a lot of myths are there, and if you talk to them, you understand how much of misconceptions are actually there in the society. Like, what kind of inner should I wear? If I have this kind of inner, is it going to have why? All those, even it might look very trivial to us, but the number of questions that they undergo in their mind is humongous. So, now I try to address the most common myths that I am aware of when I see the patient one on one. And the one thing that I ask them to do is, please, please note down all your doubts, because they'll not be able to ask us the questions upfront. It'll never be the first conversation. They're very overwhelmed about the diagnosis per se, that it might not be easy for them to ask all their doubts. So I say, go back, take a notebook or take your phone, jot down all the doubts that you have, because our meeting is not going to be the first and the last. We're going to be meeting very often. So any other doubts, however silly you might think it is, no doubt is silly, because we want them to be very clear in the mind. For them to undergo treatment, clarity is important. Clarity about the disease, clarity about the cause, clarity about the treatment side effects. Everything is important for a patient to go through that therapy. So I ask them to jot it down, come back, so that we'll address it once again. Whatever it is, we will sort it out.
Thank you so much, Dr. Ramya, for clearing that out. So, moving ahead and coming to Dr. Hollis, minimal residue disease and monitoring after treatment are becoming important areas of oncology, sir. So, how do you approach follow up care to detect reoccurrence very early?
So, ma'am, the two things that patients with cancer are afraid of, first is the toxicity of treatment, and the second is relapses and recurrences. My fellow panelists, they have discussed toxicities. Now, discussing relapse and recurrences. There's always a fear at the back of the mind. My treatment never stops. Patients will always feel that nahi, this thing can always come back. So, regular monitoring of treatment is necessary, but you should also understand that the time duration that is in the guideline protocol has to be followed. If there's a particular 1 year of treatment prescribed for trastuzumab, follow up with that 1 year of treatment. If there's a 5 year treatment of adjuvant therapy prescribed, please follow up that. Now, how do we detect relapses or recurrences? Most patients feel that there should be a simple blood test. So they will always come up with tumor markers. In breast, there is CA15.3, there is CA125 in ovary. So they'll always have this reports. I tell them do it at 3 months or 4 months, but they'll come up every month, every 2 months. This is the report that has come. So it is difficult to interpret these reports per se. So relapse and recurrences are more for us serological, that is anything that is picked up in the blood test, and radiological, that is any image has picked up. There was a trend, there is still a trend to do PET scan. Patients themselves tell me, sir, let's do a PET scan every 3 monthly or a 6 monthly annual PET scan. It depends on what is the risk of recurrence. So the baseline risk of recurrence depends on the disease biology. It depends on how aggressive the disease was, the stage of disease. So we usually go for clinical examination, and some radiology helps us, an X-ray or sonography, and definitely relevant tumor markers. But that has to be taken in toto. It has we cannot have isolated parameters to determine the risk of relapse or recurrence. Now, speaking of minimal residual disease or MRD, now this is a term that is very common in cancer, hematological malignancies. We have something called ctDNA based test. It is used to detect recurrences in malignancies like colon. Even breast has a test, but there is lack of standardization that is there. These are the tests that are more common in the western countries. Indian labs are still not have these tests that validated. So it is very difficult to prescribe these tests because interpretation becomes difficult. We usually do not treat relapses based on ctDNA without any radiology. If there's a scan image that is showing a lesion, because if the ctDNA is positive, I do not know what's the source of that ctDNA, whether it is spontaneous or what is the tumor shred, because I might not be able to markers on that test. So this minimal residual disease definitely is going to help us in the future. We need more time to understand the MRD in solid organs. In hematological malignancies, yes, it's a marker of aggressive treatment or transplant, and it could be a marker of early relapse and faster or shorter interval of follow-up of imaging. So minimal residual disease, yes, but not now. Early risk of relapses, main thing is clinical, second is radiology, and definitely some tumor markers like CA125, CA15.3 help us to a certain extent.
Thank you so much, Dr. Hollis, for that structured response for the question. Moving onwards, Dr. Lubna, as someone specializing in radiation and palliative care, how do you balance aggressive treatment with quality of life, especially in advanced cases, ma'am?
Thank you, Dr. Muskan. If we see the prevalence of breast cancer in Bangladesh, it is 22.5 women in 100,000 women found in each year. So we have done a study in outside Dhaka, that means you consider it's in peripheral region, where we found that 65% of the patient never had done any sort of screening, like not even self-examination, ultrasound or mammography, nothing. So they presented with a big painful lump, usually stage 3 and 4. It's very advanced. So it's very important to consider a meaningful discussion with the family, with the patient, and the doctors. So very careful evaluation of the disease biology, important. What is the patient condition, physical condition, financial condition as well, and expected benefit from the therapy, and centered prioritizing the quality of life. since this most of the patient we cannot cure. So quality of life is very important, and we should be goes with the stepwise, like with less toxic treatment. Toxicity means with the financial as well, with the medicine as well. So if patient is hormone positive, we should start with the hormone. If there is any target oral therapy, we should start with the oral therapy. And if there is nothing, if the chemotherapy, radiotherapy is really indicated, then we should go for chemotherapy or radiotherapy. But mostly we should discuss with the patient and family members about the benefit and what is the outcome, and what is their financial condition, patient physical condition, all of this. And integration of the supportive and palliative care is very important, though there is scarcity of resource person and the infrastructure of palliative care as well in Bangladesh. Only few centers centered mainly in the Dhaka city or palliative care, but it is started also. There's a good news. And most importantly, I feel that shared decision making important. What we learn in palliative care, not in other, when I was a medical student, rather than in palliative care setting, when I have been trained in palliative care, shared decision making. This should be the prioritized. We should explain the benefit of the treatment, possible toxicities, impact of the daily life, and the financial implication. This we all should consider during the treatment decision. So from doctors and the doctor's point of view, and also the point of view, it should be shared. And then we should take the decision what to give the treatment. Thank you, doctor.
Thank you, Dr. Lubna, for sharing the prevalence stats with us, and also how communication and shared decision making is a delicate aspect for the treatment of disease. Moving onwards to Mrs. Vandana, ma'am, my question to you is that how can support groups and community initiatives can bridge the gap between hospital treatment and emotional rehabilitation?
See, we have to divide the patient's needs in two groups. One is the medical part of it, which has to be taken care of by the doctors, because no support group can do what a doctor can do, and the doctor knows best what is the best treatment for the patient. The only request that we have from the doctors is that they should be able to explain to the patient what is to be done and how it should be done. So that is the important part. Otherwise, from the patient's point of view, we have to help them survive with dignity, and we have to help them live properly, and we have to hope that the patient can understand everything. And like I said, one of my grouse, maybe a hard word to say, is that nobody talks about the side effects which come in later. The treatment is over, the patient is okay, but nobody talks about the late side effects. So I wish the doctors would start talking about it. We should understand that cancer changes a patient's life, but with support, compassion, and care, it does not have to take away their courage or their dreams. So we need to support them, we need to be with them, we need to like we need to hold their hands and be with them to make them understand. So as a patient advocate, that is what I would do, and I expect that the doctors, I know they're very busy, they have a lot of patients to take care of, but from the patient's point of view, the patient is as important. So they request the doctors to do everything possible to guide them and do work for them. Thank you.
Thank you so much, Mrs. Vanna, for that wonderful response. So, as we are concluding towards our segment, at last I would like to invite each of you to share your perspective on one question, that if you could give one message to women and families watching today about breast cancer, whether about awareness, screening, or support, what would it be? So, we'll start with Dr. Niti.
Oh, well, breast cancer is not a disease to fear in silence. Bring it out, talk about it. And yes, it is curable when diagnosed on time. It is treatable in all stages. Go for screening regularly. And if you have a family history, visit an oncologist. So, first is awareness, early detection, and right treatment.
Thank you so much, Dr. Niti, for sharing top three segments. Dr. Hollis, would you like to add something?
Yes, ma'am. First is don't fear. Treatment is there. There are support groups that are there. There's this wonderful platform that you have made. People are there to help out, and people like Vandana ma'am are there always to help out. Doctors are there. Doctors are more sensitive than what people think they are. We are very much sensitive towards our patients, much more than what the patients think. And take home message once again is treatment is there. Just don't get afraid, and any symptoms, come to your family doctor, not to the oncologist directly, but visit the family doctor.
Thank you so much, Dr. Hollis. Dr. Ramya, would you like to give any message to the audience that are watching today?
Yes, see, it's very easy to actually start screening, but I think the acceptance is slowly increasing in our country. Be aware of your breast. Any change that is out of ordinary, don't hesitate to reach out to your family physician or anyone. That we just need someone to examine the breast. And regular screening, please come forward to do more. We screen more earlier, we pick the disease, more cure rates, less of long term side effects, less of other difficulties that you're going to have with an advanced cancer. Better treatment options, we have better supportive care also available, even to manage symptoms like nausea, for hair loss, and for all the neuropathy, all the difficulties that we do anticipate with chemo, we do have better options available to treat. So the science has improved in a way, not only for the treatment but also for the side effects. So please keep that in mind. Make sure you do regular screening. Encourage your family members also to do a regular screening. Don't hesitate to reach out for help.
Thank you so much, Dr. Ramya. Mrs. Vanna, would you like to share a message to the audience?
Now, first of all, I would like to thank all the doctors who are taking all the time to be with the patients and look after the patients. But and now, from the patient's point of view, I would like to say that the greatest medicine is not chemotherapy or surgery or radiation, but a listening ear and a compassionate hand. That makes a lot of difference. And strength in cancer patient does not mean they are not afraid. It means they continue to move forward despite the fear. So we should try and encourage to build up their strength. And we support the cancer patient. We are not only helping them to survive, we are helping them to live with dignity and hope. And the one the most important thing that I would like to convey to any person diagnosed with cancer is that don't be afraid to ask questions. It's your life, and it is the doctor who has to answer everything that you would like to know. So those are the things that I really think are important for me. Thank you.
Thank you so much, Mrs. Vanna. So, with that, we conclude our today's conversation. Thank you so much to all the panelists here for joining us. Thank you so much, everyone.
Thank you, Dr. Muskan. Thanks for having us here.
Thank
Thank you,
you.
ma'am.
Thank you very much. Thank you.
Bye bye. Thank you.